Try to picture this. It's 1963. You're 68 years old. You've worked your entire life, maybe on a factory floor, maybe behind a counter, maybe on a farm where the sun never seemed to stop punishing your back. And now your body is finally giving out. Your knees ache, your chest tightens when you climb the stairs. The doctor says you need surgery, and the bill is going to be more than you made in an entire year during the best years of your career. You have no health insurance. Nobody will sell you a policy because insurance companies consider you a bad risk. You're old, you're sick, and you're expensive. Your savings, what little you manage to put away, won't cover it. Your children are raising families of their own and can barely make rent. And the government? The government has almost nothing for you. No program, no safety net, no plan. You're on your own. This was not some rare extreme situation. This was the everyday reality for tens of millions of elderly Americans. Before 1965, there was no Medicare. There was no federal health insurance for seniors. The consequences of that absence were devastating, not just financially, but physically, emotionally, and in ways that shaped entire families for generations. Nearly 30% of Americans over the age of 65 lived below the poverty line. Only about half of them had any kind of health insurance at all. And the half that didn't, they faced impossible choices. The kind of choices that no one in a country as wealthy as the United States should ever have had to make. So, how did they survive? How did your grandparents or your great-grandparents deal with a broken hip or pneumonia or cancer or any of the 1,000 things that go wrong with the human body after decades of living? That's what we're going to explore today. And the answer is not a simple one. It involves charity wards and poorhouses, fraternal lodges and church basements, family sacrifices and political wars that lasted longer than most people realize. It's a story about what happens when the richest nation on earth decides, for decades, that the health of its oldest citizens is simply not its problem. Let's go back even further to understand the world that created this crisis, because the truth is, for most of American history, the very concept of health insurance didn't exist. Not just for seniors, for anyone. Before the 20th century, if you got sick or injured, you had exactly 3 options. You could pay the doctor out of your own pocket. You could rely on your family to care for you. Or, if you had neither money nor family, you could throw yourself on the mercy of charity. And charity in those days often meant the poorhouse, also known as the almshouse. These institutions had existed in America since colonial times, modeled after the English poor laws that treated poverty as something dangerously close to a moral failing. The Philadelphia Almshouse, one of the first government-sponsored facilities for the destitute in America, opened its doors in 1732. It wasn't a hospital. It was a dumping ground. The elderly, the mentally ill, orphans, people with disabilities, anyone society deemed unable to care for themselves, they all ended up in the same overcrowded, underfunded building. By the 1820s, reformers like Josiah Quincy in Massachusetts and John Yates in New York pushed to build poorhouses in every town and city across the country. Some were small, almost home-like, with a superintendent and his unpaid wife managing a dozen residents. Others, particularly in large cities, were grim, concrete institutions where hundreds of people were warehoused together with minimal care. The conditions inside many of these places were nightmarish. Filthy bedding, rotten food, no medical treatment to speak of. For elderly Americans without family or savings, the poorhouse wasn't just a possibility, it was an expectation. It was where you went to die. And here's the thing that people often forget. Hospitals themselves, for most of the 19th century, were not places where respectable people went. If you had money or family, you were treated at home. A doctor would come to your house, examine you, maybe perform minor surgery right there on your kitchen table. Hospitals were for the poor and the desperate. They were charity institutions funded by churches and wealthy benefactors. And their primary purpose was not healing so much as containment. Keep the sick and the destitute off the streets. Keep them out of sight. That was the unspoken agreement. But something started to change in the late 1800s and early 1900s. Medical science was advancing rapidly. Antiseptic techniques, anesthesia, X-rays, new surgical procedures. These innovations transformed hospitals from warehouses for the dying to places where real healing could happen. And with that transformation came a fundamental shift. Hospitals became expensive. The equipment, the trained staff, the medications, none of it was cheap. And suddenly, the question of who was going to pay for all of it became urgent. For working-age adults, the answer eventually arrived through an accident of history. But for the elderly, the answer would take decades longer to come. And in the meantime, millions of people suffered. Now, before we get to how that answer finally arrived, we need to understand the patchwork of systems that elderly Americans cobbled together to survive. Because people didn't just lie down and accept their fate. They fought. They improvised. They leaned on each other in ways that were sometimes beautiful and sometimes heartbreaking. The first and most common strategy was simply paying out of pocket. If you had savings, you spent them. If you had property, you sold it. If you had anything of value at all, you liquidated it to cover medical bills. And the bills could be staggering. A hospital stay in the 1950s might cost several $100s, which doesn't sound like much until you realize that the median income for Americans over 65 at that time was roughly $1,000 a year. A single hospitalization could wipe out half your annual income or more. A serious illness requiring multiple hospital stays could destroy everything you'd spent a lifetime building. The numbers tell a bleak story. Studies from the early 1960s found that elderly Americans spent more than twice as much on healthcare as a percentage of their income as younger adults. And they earned far less. The average person over 65 had an income that was roughly half that of someone in their working years. So they were paying more from a smaller part of money for care they desperately needed. It was a mathematical trap with no exit. The second strategy was family. And this is where the story gets personal, because millions of American families were reshaped by the burden of elder care. Adult children took their aging parents into their homes. Daughters, almost always daughters, quit their jobs to become full-time caregivers. Families pooled their resources, sometimes 3 generations living under one roof, sharing expenses and responsibilities that none of them could manage alone. This wasn't just an inconvenience, it was a structural feature of American life. Researchers from the National Bureau of Economic Research later found that higher Social Security benefits actually allowed more elderly Americans to live independently rather than with family members, suggesting that many of those multi-generational households existed not out of cultural preference, but out of sheer financial necessity. When Grandma moved in, it wasn't always because the family wanted her there. It was because she had nowhere else to go. And for those without family or whose families couldn't help, there was charity care. Hospitals, particularly religious and non-profit institutions, maintained what were called charity wards. These were sections of a hospital designated for patients who couldn't pay. The care was basic, sometimes barely adequate, and the experience could be deeply humiliating. Patients in charity wards were often treated as teaching cases for medical students. Their privacy was limited. Their dignity was an afterthought. But at least they received some form of medical attention, which was more than many elderly Americans could say. Fraternal organizations also played a surprisingly significant role. Groups like the Odd Fellows, the Masons, the Knights of Columbus, and various ethnic benevolent societies, Irish, German, Hebrew, Italian, these organizations operated like early insurance programs. Members paid monthly dues while they were young and healthy, and in return, they could receive care when they aged or fell ill. Some of these groups even built their own homes for the elderly, facilities that were far superior to the public poorhouses. In Brooklyn alone, by the end of the 19th century, you could find dozens of these fraternal care facilities. The Baptist Home, the Brooklyn Home for the Aged, the German Evangelical Home. But these systems had obvious limitations. They were local, they were small, they were often tied to specific ethnic or religious communities, and they couldn't come close to meeting the scale of the need. As the 20th century progressed and medical costs kept climbing, even these well-intentioned institutions found themselves overwhelmed. Now, here's where the story takes a critical turn, because the question of how to pay for healthcare in America wasn't just a practical problem, it was a political war. And that war was fought for decades before anything resembling a solution emerged. The first real attempt to create some kind of health insurance system in the United States came not from the government, but from a university administrator in Dallas, Texas. In December of 1929, just weeks after the stock market crash that would plunge the nation into the Great Depression, a man named Justin Ford Kimball took over operations at Baylor University Hospital. Kimball had been a school superintendent before moving into hospital administration, and when he studied the books, he noticed something troubling. A huge number of unpaid bills belonged to local school teachers. These were educated, employed professionals, and even they couldn't afford to pay for hospital care. So, Kimball devised a plan that was breathtaking in its simplicity. For 50 cents a month, $6 a year, teachers could prepay for up to 21 days of hospital care at Baylor. It was a win for the teachers, who now had some protection against catastrophic hospital bills, and it was a win for the hospital, which now had a steady stream of guaranteed income instead of a growing pile of unpaid debts. The Baylor Plan, as it came to be known, was an immediate success. More than 1,300 teachers enrolled. Other employee groups across Dallas soon joined, and the idea spread. By the early 1930s, similar prepaid hospital plans were popping up all over the country. In 1933, a Minnesota hospital administrator named E.A. Van Steenwyck designed a poster for his local plan featuring a blue cross, the universal symbol of healthcare, and a Latin motto. The name stuck. These prepaid hospital plans became known as Blue Cross. Blue Shield plans followed soon after, covering physician services rather than hospital stays. The California Physician Service launched in 1939 using a blue shield bearing a caduceus as its symbol. Together, Blue Cross and Blue Shield became the foundation of private health insurance in America. But here's the critical detail that shaped everything that followed. These plans were designed for workers, for employed people, for groups of employees whose employers could negotiate rates and guarantee enrollment. They were not designed for the retired. They were not designed for the elderly. And they were certainly not designed for people who were already sick. This gap became even more pronounced because of another accident of history, one that would lock the American healthcare system into a structure that still defines it today. When the United States entered the Second World War, the federal government faced an urgent problem. With millions of men shipping overseas to fight, factories desperately needed workers to keep the war machine running. But inflation was spiraling, prices were rising, and the government feared that if wages rose unchecked, the economy would collapse into the kind of hyperinflation that had devastated Germany after the First World War. So, in October of 1942, Congress passed the Stabilization Act, giving President Roosevelt the power to freeze wages and prices across the entire economy. Employers were forbidden from offering higher salaries to attract workers. The penalty for violations was a fine of up to $1,000, imprisonment for up to a year, or both. But the Stabilization Act contained a crucial loophole. It excluded insurance and pension benefits from the wage freeze. Employers couldn't offer more money, but they could offer health insurance. And that's exactly what they did. Faced with a desperate labor shortage and unable to compete on wages, companies began offering group health insurance as a way to attract and retain workers. What had been a rare perk offered by only the most progressive employers suddenly became standard practice. The numbers tell the story. In 1940, fewer than 10% of Americans had any form of health insurance. By 1950, that number had exploded. Employer-sponsored health insurance became the dominant way that Americans accessed medical care. And in 1954, the Internal Revenue Service ruled that employer contributions to health insurance were tax-exempt, cementing the system even further. But notice who was left out of this arrangement. Retirees, the elderly, people who no longer had an employer to provide them with coverage. The very people who needed health care the most were the ones least likely to have it. Private insurance companies considered them bad risks, too old, too sick, too expensive. Premiums for individual policies, if you could even find one willing to sell to you, were astronomical. And the employer-based system that covered most working Americans simply evaporated the moment you retired. This created a cruel paradox. The generation that had survived the Depression fought the war, and built the post-war economic boom, was being abandoned by the very system their labor had created. They had worked their entire lives, paid their taxes, raised their families, and now, in their most vulnerable years, they were on their own. And people noticed, politicians noticed, activists noticed, and the fight for government health insurance for the elderly became one of the most bitterly contested political battles of the 20th century. The first serious push came from President Harry Truman. In November of 1945, just months after the end of the Second World War, Truman sent a special message to Congress calling for a comprehensive national health insurance program. It wasn't just for seniors. Truman wanted universal coverage for all Americans, funded through a payroll tax similar to Social Security. He had been struck during the First World War by the number of men deemed unfit for military service due to poor health, and he believed it was a national disgrace that millions of Americans couldn't afford basic medical care. A Gallup poll at the time found that 59% of Americans supported Truman's plan. The public wanted it. But the American Medical Association, on the AMA, the powerful lobby representing the nation's doctors, did not. The AMA launched what historians consider one of the first modern political propaganda campaigns in American history. They hired a public relations firm called Whitaker and Baxter, the same outfit that had pioneered political consulting in California. They poured millions of dollars into a campaign to defeat Truman's proposal. Their weapon of choice was a single phrase: socialized medicine. The AMA claimed that government health insurance would turn doctors into slaves. They distributed pamphlets, ran radio ads, and organized their member physicians to lobby against the plan in every congressional district. They insisted that private employer-provided insurance was the American way, and that government involvement in healthcare was a step toward communism. In the anti-communist of the late 1940s, with the Cold War intensifying and fear of Soviet influence spreading through every corner of American life, these tactics proved devastatingly effective. A House subcommittee investigating national health insurance reached what it called a firm conclusion: that American communism held the program as a cardinal point in its objectives. The AMA's own campaign materials warned doctors and dentists that the proposal would lead to government control of every aspect of medical practice. One telegram to physicians flatly stated that the plan would mean the end of medical freedom in America. Truman fought back. During his 1948 campaign, he blasted the do-nothing Republican Congress for capitulating to health industry lobbies. He argued that providing health care was not un-American, but was in fact simple Christianity. But by 1950, his plan was dead. The AMA had won. National health insurance was off the table. And so the system continued. Workers got their insurance through their employers. The elderly got nothing or next to nothing. Throughout the 1950s, the debate shifted. Advocates for government health insurance realized that pushing for universal coverage was politically impossible. The AMA was too powerful, the anti-communist rhetoric too effective. So they narrowed their focus. Instead of fighting for everyone, they would fight for the most sympathetic group imaginable: elderly Americans. The logic was simple. Seniors were undeniably vulnerable. They were sicker than younger Americans. They had less income. They couldn't get private insurance. And unlike other uninsured groups, they couldn't be easily dismissed as lazy or undeserving. These were people who had worked their entire lives. They had earned the right to basic medical care. Or at least, that was the argument. In 1957, a bill was introduced in the House of Representatives that would provide health insurance to Social Security beneficiaries. It was referred immediately to the House Ways and Means Committee, chaired by a conservative Arkansas Democrat named Wilbur Mills. Mills was cautious, meticulous, and deeply skeptical of any program that might strain the federal budget. He sat on the bill, and he kept sitting on it. Meanwhile, the problem was getting worse. Hospital costs were rising sharply. Private insurers were being forced to increase premium rates for elderly policyholders, pushing even more seniors out of the market. A study by the Federal Council on Aging found that a hospital stay for an elderly patient cost an average of $700, a sum that represented months of income for most retirees. In 1960, Congress made a halfway attempt to address the crisis. The Kerr-Mills Act created a program called Medical Assistance for the Aged, which provided federal matching funds to states that chose to cover healthcare for elderly residents who earned too much to qualify for welfare but too little to afford medical care on their own. It was a means-tested program, meaning you had to prove you were poor enough to deserve help, which involved invasive investigations of your finances and often required you to deplete nearly all of your resources before you qualified. The Kerr-Mills program was a failure by almost any measure. 3 years after the law was passed, fewer than half the states had implemented it. In the states that did participate, coverage was uneven and inadequate. A Senate subcommittee report found that the program suffered from major defects and that there was no reason to expect it would ever become a truly national program. In most states, the cumbersome eligibility process humiliated applicants and discouraged them from seeking help. You essentially had to prove you were destitute before the government would lift a finger. And so, the status quo ground on. Elderly Americans continued to go bankrupt for medical bills. They continued to skip medications they couldn't afford. They continued to avoid doctors until their conditions became emergencies. They continued to die from treatable diseases because treatment was simply beyond their reach. Then came 1963.
President John F. Kennedy had been pushing for Medicare, a health insurance program for the elderly funded through Social Security, but he couldn't get it through Congress. Wilbur Mills, still chairing the Ways and Means Committee, continued to block it. The AMA continued to fight it. The political arithmetic simply didn't add up. And then Kennedy was assassinated, and everything changed. Lyndon Baines Johnson took office with a mandate born of national tragedy and personal ambition. Johnson was a legislative genius, a master of the Senate who understood the mechanics of power better than almost anyone in American history, and he made Medicare one of his top priorities. But Johnson was also a pragmatist. He knew that simply ramming a Medicare bill through Congress would create enemies he couldn't afford. So he used Kennedy's death, the national mood of grief and purpose that followed it, and his own formidable political skills to build an overwhelming coalition. In the 1964 presidential election, Johnson won by one of the largest margins in American history, carrying 44 states and bringing huge Democratic majorities into both the House and the Senate. Wilbur Mills read the political winds. The man who had blocked Medicare for years suddenly transformed himself from its greatest obstacle into its chief architect. And what Mills did in early 1965 was genuinely brilliant. Republicans on his committee had proposed their own alternative to the administration's Medicare plan, a voluntary supplemental insurance program that would help cover doctors' bills. Rather than fight it, Mills folded it in. He took the administration's proposal for mandatory hospital insurance, combined it with the Republican plan for voluntary physician coverage, and added an expanded version of the Kerr-Mills program for the poorest Americans. Johnson called it the three-layer cake. The first layer was Part A, mandatory hospital insurance for the elderly, funded through an increase in payroll taxes. The second layer was Part B, voluntary supplemental coverage for doctor visits and other medical services, funded through a combination of general tax revenue and premium contributions from recipients. The third layer was Medicaid, a new federal state program providing health coverage for the poor and disabled. On March 24, 1965, the Ways and Means Committee voted on the bill. The result was a straight party line vote, 17-8. The bill moved to the full House, then to the Senate, and on July 30, 1965, President Johnson boarded Air Force One and flew to Independence, Missouri. He chose the location deliberately. He was going to the Truman Presidential Library, and standing beside him at the signing ceremony was 81-year-old Harry Truman, the man who had first proposed national health insurance 20 years earlier and been defeated by the AMA's propaganda machine. Johnson signed the Social Security Amendments of 1965 into law. Then he turned to Truman and presented him with the first Medicare card. Bess Truman received the second. It was a moment of vindication that had been 2 decades in the making. Johnson's words at the ceremony captured both the ambition and the relief of the moment. He declared that no longer would older Americans be denied the healing miracle of modern medicine. No longer would illness crush and destroy the savings that families had so carefully put away. No longer would young families see their own incomes eaten away because they were carrying out deep moral obligations to their parents. The numbers that followed tell the story of transformation. In 1964, only 51% of Americans over 65 had any form of health insurance. After Medicare, coverage became virtually universal. In 1964, nearly 30% of seniors lived below the poverty line. That number would eventually fall to single digits. In the program's first year, 19 million Americans enrolled. Today, Medicare covers nearly 70 million beneficiaries. But here's what makes this story more than just a legislative triumph. Medicare didn't just change how seniors paid their hospital bills. It changed what it meant to grow old in America. Before 1965, aging was a descent into vulnerability. You worked until your body gave out, and then you prayed that your savings, your family, or the charity of strangers would be enough to see you through. After 1965, there was a flaw. It wasn't perfect. It had gaps and limitations and problems that would be debated for decades to come. But it existed. For the first time in American history, the government acknowledged that its oldest citizens deserved at least a basic guarantee of medical care. And the impact on health outcomes was dramatic. Before Medicare, only 69% of seniors saw a physician in any given year. After Medicare, that number climbed to 96%. Life expectancy at age 65 increased by 15 years between 1965 and 1984. While that increase can't be attributed entirely to Medicare, without its coverage, millions of elderly Americans simply would not have had access to the medical advances that contributed to those gains. But we should also be honest about what Medicare didn't solve. The program was designed to work within the existing healthcare system, not to reform it. Hospitals were allowed to determine what constituted reasonable costs and bill accordingly. Physicians were reimbursed based on their prevailing local rates. There were no real controls on spending. And as a result, healthcare costs began to climb almost immediately after Medicare's passage, a trend that has continued for more than 60 years. The AMA, which had fought Medicare tooth and nail, adapted quickly once the money started flowing. Doctors who had warned that government insurance would destroy American medicine discovered that it actually made them richer. Medicare paid well, and it paid reliably. Within a few years, the medical profession's opposition had largely evaporated, replaced by enthusiastic participation in a system that guaranteed payment for treating the nation's most medically intensive population. And the political dynamics shifted too. Medicare became what political scientists call a third rail, an issue that politicians touch at their peril. Once tens of millions of seniors had experienced the security of guaranteed health coverage, any attempt to take it away became political suicide. The program that had been called socialized medicine, communism, and un-American by its opponents became one of the most popular government programs in American history. But let's return for a moment to the world before all of this, because the pre-Medicare era wasn't just a policy failure. It was a human catastrophe that played out in millions of individual lives. There was the retired steelworker in Pittsburgh who put off a hernia operation for 3 years because he couldn't afford it, until the hernia strangulated and he was rushed to the emergency room, where the surgery that would have cost a few $100s preventatively now cost thousands. There was the widow in rural Mississippi who rationed her heart medication, cutting pills in half to make them last twice as long because she couldn't afford a refill. There was the retired schoolteacher in Ohio who sold her house to pay for her husband's cancer treatment and then, when the money ran out, watched him die in a charity ward. These weren't exceptional stories. They were ordinary ones. They were the daily fabric of American life for millions of elderly citizens before 1965. And they represent something profound about the choices a society makes about who deserves protection and who doesn't. The story of how America got Medicare is ultimately a story about how long it takes a democracy to do the right thing. The idea was first seriously proposed in 1945. It became law 20 years later. In between, millions of elderly Americans suffered and died unnecessarily, while politicians argued, lobbyists schemed, and the wealthiest nation in the history of the world debated whether its oldest citizens deserved basic medical care. And the forces that delayed Medicare for 2 decades weren't mysterious or complicated. They were the same forces that have shaped every major social policy debate in American history. The tension between private profit and public good, between individual liberty and collective responsibility, between the fear of change and the cost of inaction. The AMA spent millions fighting Medicare because it threatened to reduce physicians' autonomy and potentially their income. Insurance companies opposed it because it represented government competition with the private market. Conservative politicians called it socialism because that label had proven effective at killing progressive legislation since the late 1940s. And many ordinary Americans, even those who might have benefited from the program, were persuaded by these arguments, at least for a time. But in the end, the reality on the ground was too stark to ignore. Too many people were suffering.
Too many families were being destroyed by medical bills.
Too many elderly Americans were dying from conditions that modern medicine could treat. The moral case for action eventually overwhelmed the political case for inaction. What's remarkable, looking back, is not just how long the fight took, but how decisive the result was. Once Medicare passed, it transformed American society so completely that it's now almost impossible to imagine life without it. The program that was called a radical experiment and government overreach became as American as Social Security itself, a fundamental promise between the nation and its citizens. And today, more than 60 years later, the echoes of that pre-Medicare world still reverberate. Every debate about healthcare costs, about expanding or cutting benefits, about the role of government in medicine, is really a continuation of the same argument that started when Harry Truman sent his message to Congress in 1945. The names change, the specifics change, but the fundamental question remains the same. In the richest country on earth, who deserves access to medical care and who should pay for it? The generation that lived through the pre-Medicare era is almost entirely gone now. But their experience, their suffering, and the system that was built in response to it, that legacy is still very much with us. Medicare didn't just give seniors a way to pay their hospital bills. It redefined the social contract between America and its aging citizens. It said that after a lifetime of work and contribution, you would not be abandoned. You would not be left to die in a charity ward or a poorhouse. You would be cared for. Whether that promise can be sustained, whether it will be expanded or eroded, whether the lessons of the pre-Medicare era will be remembered or forgotten, those are questions that belong to the future. But the story of how we got here, the decades of struggle, the political battles, the millions of lives that hung in the balance, that story deserves to be told. Because understanding where we came from is the only way to understand where we're going. If you made it this far, I'd love it if you could drop a stethoscope emoji in the comments. And if you haven't already, please subscribe to this channel. We put a lot of work into these deep dives, and your support genuinely makes a difference. I'll see you in the next one.